My name is Diana Nieves. I'm Chief Development and Involvement Officer at the LifeRaft Group. And before we begin, I just wanted to say a quick thank you to our sponsors. Thank you to them, Cogent Biosciences, Decipher, Genentech, IDRX, and Thesis. I also want to give a huge thank you to Vanderbilt Ingram Cancer Center for partnering with us for this GDOL today. I'm super excited to be working with them and have them here with us again for this GDOL, and also introduce Dr. Elizabeth Davis. I'm so excited she's here, and she's an associate professor of medicine and medical director of clinical trials at Vanderbilt. And I was doing a little research and I found some comments, reviews about Dr. Davis. And I just wanted to leave you all with this, that she's a very caring, concerned, compassionate person. And she just takes the time to address each person individually and without even knowing their chart, but just focusing on their care. So I just wanted to leave everyone with that note. So Dr. Davis, thank you for joining us today, and I'll hand over the mic to you.
Thanks so much, Dan. I appreciate that. And that's a very kind words. Thank you everyone for joining us this afternoon. Vanderbilt is very happy to host another GDOL. Our last one we really enjoyed participating in, and we received a lot of really nice feedback from the people that we serve. So we're hopeful that today's session will be just as informative and enjoyable for everyone. So we have an exciting program filled with lots of different members of our sarcoma team. The format for today's session is going to include some brief talks by a lot of different people. We tried to ask everyone to leave a brief amount of time for some questions, but we also built in a Q&A session at the very end of the program. And so if you have questions, feel free to throw them into the chat. Also during the Q&A, you can use the raise hand function, and then someone will call on you, maybe me or Diana, I don't know. We'll see how that goes. But hopefully there will be lots of engagement, and yes, feel free to ask questions if you have them. So leading us off today is Dr. Prieto Granada. He is a pathologist here at Vanderbilt, and he's going to talk about the importance of pathology in the diagnosis of GIST. So thanks, Carlos, for being here.
Oh yeah, hello everyone. Let me see. Let me share my screen. Can you guys see my screen?
Yes, it looks great.
All right. So I wanted to talk about what we do in pathology for the diagnosis of GIST real quickly. So I'm gonna go, through several. I don't know if this is obstructing the view or not. There we go. Guess I should have put the presenter mode or something. Anywho, should have known by now. Huh? Quick overview about how we diagnose GIST in the lab. Basic tumor classification of the GI tract to put us in context, historical aspects of GIST, and how we specifically reach that diagnosis in the lab. Then a little bit about risk stratification based on pathologic features, and a tiny bit about molecular aberrations. I know that will be expanded further. So as you know, GIST can be very non-specific in their symptomatology, and usually it's incidentally diagnosed by endoscopy. Here you can see a tumor being spotted during endoscopy of the GI tract, and the majority of the tumors will arise in the stomach and the small intestine, almost 90% of them. And then imaging studies, of course, can help in spotting the tumors. Here we can see a couple of CT scans, one with a tumor in the stomach, the other one with a large tumor in the small bowel. So so what we do in the lab is, once they diagnose, and they sometimes they do a biopsy, and that will trigger a resection. We'll get all those specimens in the lab. And this is an example of a small bowel resection with a large tumor that is involving the outer portion of the bowel. So that goes to the pathologist assistant who grows the specimen. So that means they slice the tumor, they take sections from the margins, and that goes, and those little pieces of tissue go through a process of dehydration, paraffin embedding, which ends up in this nice wax or paraffin block with the tissue inside. So that we section and we stain with a couple of dyes, hematoxin and eosin, and that results on this in these glass slides that we look in the microscope. So that's how we end up with the product that we use to diagnose the majority of tumors. So to go through basic, I don't know why to go through the basics of GI classification of tumor. Sorry? Excuse me?
His
Mike is cutting out.
yeah, appears to be.
If everyone can please mute themselves.
Yeah.
You.
Anyway, so there we go. So classification of tumors in the GI tract. So we have our epithelium. So this is kind of like a small bowel that is cut transversely. So we get this circle, right? So here inside we have the lumen or the middle of the tube of the small bowel. So lining that that space are epithelial cells. So those epithelial cells give rise to the most common type of tumors, which are ionomas, which are the benign or atypical epithelial tumors, and the ionocarcinomas, which are the malignant, like cold ionocarcinoma, which is the most common. But we also have smooth muscle, a type of specialized muscle, which is part of the mesenchymal or soft tissue part of the bowel. So that can give rise to smooth muscle tumors, neural tumors, and gastrointestinal stromal tumors. So where do these come from? So these come from these specialized cells called Cajal cells. So these cells were described back in the 19th century by these very prolific guys, Spanish scientists that made these beautiful drawings and studied the brain and various organs with very beautiful drawings. And he used these silver impregnation stains that are stain everything black. So he described actually these cells that are present in the small bowel, within the small bowel layer of the GI tract. So these Cajal cells are these stellate cells that are kind of hooked to these kind of portions of the autonomous nervous system, which is like the automatic nervous system of the bowel. So these cells over here, which are the Cajal cells, are basically in charge of, now we know that in charge of the motility of the bowel. So basically they're kind of like the pacemakers. As we have a pacemaker in the heart, we have pacemakers also in our gastrointestinal system. And this was discovered in the 90s. Before that, we were calling all sorts of different names. Yeasts were called all sorts of different names, a variety of different names that were not accurate. So in the 90s, there were this series of experiments where they figured out that these gastrointestinal stromal tumors were derived from these Cajal cells. So there is a marker for these cells, which is CD117 or c-KIT, which we can also use to find these cells in a normal smooth muscle bowel, layer of the bowel here, like in this picture. So they're very slender and they have all these little processes that connects them to the smooth muscle cells. So how, once we get the section, if you remember, go back to that first picture. So we get the slides. So we get, microscopic images of the tumor that is located here in the smooth muscle layer. So basically, we classify them as spindle cell type if they have these elongated cells, or epithelial cell type if they're more, they look like epithelial cells, but not really epithelial cells. They're not elongated. They're more stubby and round and polygonal. Or sometimes we have mixed epithelial and spindle cell type. And the most important thing that we do with these H&E stains, as we call it, is look for mitosis. So mitosis are evidence that the tumor cells are replicating or dividing. So basically, we have to look for mitosis in 5 millimeters squared, which basically equates to 50 high power fields. So basically, we go to the highest magnification in our microscopes, and we go and count 50 of those fields, and we look for mitosis. And the other things that we consider in our report are location of the tumor, small bowel versus gastric versus other. But the most common ones, as we said, is small bowel and stomach, and then the size of the tumor, which is, seen grossly in the section specimens. So, and then how do we know that it's a GIST? We confirm that it's a GIST by immunohistochemistry. So immunohistochemistry basically, quick and dirty, is we direct an antibody with a dye to a specific marker, to a specific protein that allows us to identify the tissue. So basically, we use this technique to stain these tumors for CD117 and for DOG1. And as you can see here, all these brown cells are positive for these markers. So these are GISTs. So DOG1 actually spells discovered on GIST. So it's a marker that's relatively specific and sensitive for these tumors. So why do we count mitosis and take a consideration of the size? Because we have this risk stratification based on location, size, and mitotic count. Basically, so we divided in gastric and small intestine tumors. So we take, the tumors are that show 5 or less mitotic figures per 50 high power fields, and then the ones that show more than 5. So that's the main divider there. And then we stratify them by size. So less than equal 2 centimeters to 5, more than 5 to 10, and more than 10. So we assign a risk based on that, location and the combination of these two parameters. So this is kind of like the sample report. So I know you guys get reports now. We all get reports. I recently actually got a benign tumor size from my thigh, and I actually signed out that tumor. I reported the tumor, and I immediately got it in the app. So you guys get this even before the physicians. So a quick and dirty, guide about the what you expect in a pathologic report. So the diagnostic line, you will have like the heading, which is telling you where that tissue is coming from. And then the diagnostic line here, as you see, and then I usually give the size. And then in this particular lesion, this patient had multiple GISTs. So multifocal, meaning that there are multiple of those tumors that were seen, and the largest measured 4.6 centimeters. And this is the risk assessment that we talked about. Then we go over the margins, so that this means that there was no tumor at the margin where they cut the tumor out. And then the lymph nodes, the lymph nodes are usually associated with the bowel that were negative. And then in the comment section, I tend to put, the immunohistochemistry that we use. And then here I say that multifocal gastrointestinal stromal tumors associated with this neurofibromatosis 1 syndrome. And down here we have the clinical information. And this would be the biopsy. A biopsy will not have margins, for example, will not have size, because we only get very tiny pieces of tissue. So again, the diagnostic line, where the tissue was obtained, and the comments. And then here we have the gross description, which is how the tumor looked grossly, or the specimen looked grossly. So very quickly about the molecular aberrations in GIST. So we know that the great majority of them have these KIT and PDGFRA aberrations, and then a minority will have other tyrosine kinase aberrations like BRAF, or the other one is NF1, which is not really a tyrosine kinase, but is included there, very low percentage. And then the other important one are succinyl dehydrogenase aberrations. This enzyme is part of the Krebs cycle that occurs in the mitochondria, so it has been recently described to be very important. Several of these components have been recently described to be very important in the genesis of various different tumors. So, and then this is important because both KIT and PDGFR are sensitive for Gleevec. It inhibits the abnormal protein that's turned on, continuously turned on by the mutation that is found in these tumors. So that's a way we block the downstream effect of this protein. So the GIST are relatively rare mesenchymal neoplasms involving the GI tract, and we saw that they derive from or differentiate towards interstitial cells of Cajal, which are usually the pacemakers of the bowel. And we saw that tumor size, mitotic activity, and the presence of metastases, of course, affect prognosis. And fortunately, they have the great majority of them tend to have KIT and PDGFR A mutations that are sensitive to imatinib. And I think that's it. I don't know if I went too fast, but I'm glad to take questions.
Wonderful. Thanks, Carlos. I think we're going to hold on questions for right now, just to try to stay a little bit on time. And then I think we do have some time built in at the end. So we're going to kind of keep going for right now, but thank you so much. That was incredibly informative, and I think enlightening to kind of see what happens behind the scenes and what results in all those messages in your health portal. Okay, so now we're going to move to Dr. Vicki Keedy, who's the director of our sarcoma program here at Vanderbilt, and she's going to talk about genomics and imatinib and GIST. Thanks, Vicki.
Hi, everybody. Thanks again to LifeRaft Group and Dr. Davis, and again, all of our sponsors for allowing us to do this. It's great to see everybody as our group, also our patients outside of the clinic room. So I'm going to go into just a little bit more detail on the last kind of topics that Dr. Prieto-Granata went over. Specifically going to discuss genomics with the genetic mutations within GIST, as well as the role of imatinib. And then Dr. Davis is going to discuss some of the other therapy options. All right, I'm going to try to keep us on time, but I like to talk about GIST and sarcomas a lot, so bear with me. All right, but my slides aren't going forward. Okay, so you've already heard a little bit of this background and discovery, but when I talk about GIST, particularly to our trainees, it really is sort of one of the epitome or first landmark solid tumors where we identified treatments other than chemotherapy, or what we call cytotoxic chemotherapy and hormonal therapy. And it's really fascinating once the discoveries were made, how quickly things actually changed. And so as you've already heard, we didn't know what these tumors were for many years. And it wasn't really until the 80s and 90s that they were identified as a unified tumor. And around that time is when KIT was identified, and then their relationship to those interstitial cells of Cajal. And so once they were identified as a singular malignancy, then they could be studied in more detail. And so that's really where the changes happened. And so what is c-KIT? And I need that animation because it's much better than the drawings that I have. But basically c-KIT and PDGFR are called transmembrane tyrosine kinases, or tyrosine kinase receptors. And our normal cells have these all kinds of different receptors all over their membranes. And it's pretty amazing. It's kind of the signaling pathways that have to be turned and off to make sure our cells are functioning in a normal way. So KIT has a normal function within our cells, and within the cells in the GI tract, it's to have these cells to turn into these interstitial cells of Cajal. And again, in that animation, you saw that there's something called a ligand that has to bind to the part of the receptor that's on the outside of the membrane. And that causes these two receptors to bind together. And then once that happens, there's a source of energy called ATP that activates the signals that then go and turn on lots of different processes within the cell themselves. And so if the ligand isn't there, then this isn't happening. Well, what happens in mutated KIT or PDGFR is that phosphorylation or that activation of the signal happens regardless of there being a ligand. And we call that constitutive activation. So it does not require any type of ligand at all. And where this happens is in these mutations are actually in the DNA or the genetic code of the cell that then lead the code that leads to the formation of these particular receptors. So to kind of move forward into our history, the mutations were identified in GIST. So we said, okay, well, you know, how is KIT important? And started looking and seeing that there were actually mutations within KIT. And it just so happened around that time, this drug called imatinib was being developed for a completely different type of cancer called chronic myelogenous leukemia. And it wasn't until 2006 that PDGFR mutations were actually reported. And in the lab, imatinib activity was reported against KIT mutations in the late 1990s, so not that long ago. And so what are these mutations look like? And for those of you who have seen your mutation testing, you'll see we talk about KIT, we talk about PDGFR, but then you'll also see these words exon 9, exon 11, and what do those mean? So the exons, where we report those, is where in that genetic code that mutation happens. And based on where that mutation is, it changes the structure of the receptor. And so if the mutation is in the part of the genetic code in exon 9, then this part of the receptor changes shape versus if it's exon 11, this part of the receptor changes shape. And that change in shape allows those signals to activate without a ligand. And PDGFR has a very similar structure, but you can see that the most common mutations happen in slightly different regions for reasons we still don't quite know. But in KIT, exon 11 is the most common primary mutation, with only 10% being exon 9, and then a far lower number occurring in the PDGFR regions. These other mutations are called secondary resistance mutations. So they're mutations that can happen after the fact that lead to resistance to imatinib. So how does imatinib work? So it's called a tyrosine kinase inhibitor, or actually a multi-tyrosine kinase inhibitor. It's not specific to only imatinib and PDGFR, but quite active at those receptors. And so basically what happens is, so when that receptor is activated, this ATP can bind to it and lead to these signals. But imatinib is actually shaped to fit into these pockets to prevent ATP from being able to bind, and the signal is turned off. So with that discovery, we then decided to try imatinib in patients with metastatic GIST. And the first report was actually in 2000, was a single case report of a single patient who had metastatic GIST who had a remarkable response to imatinib. And from there started the small phase 1-2 clinical trials, and then eventually the drug approval. And so what the study did, it was actually all the patients in this clinical trial received imatinib. Half the patients received 400 milligrams, half the patients received 600 because they really didn't know what the best dose was at that time. And you can see some pretty remarkable responses compared to what we had seen with chemotherapy. We know that GIST is not sensitive to the standard cytotoxic chemotherapies. And so we were seeing partial responses, so meaning tumor shrinking by more than 2/3 in in over 2/3 of patients, including some patients who had their tumors completely shrink away or go away. And a very small portion of patients had their cancer, their GIST grow while on imatinib. And what that led to was for the people whose GIST had responses to imatinib, those patients lived significantly longer than if the GIST did not respond to imatinib. And I'll kind of talk about that population a little bit more, but going into the imatinib side effects. So anyone who's been on this drug, we tend to think of it as a relatively well-tolerated drug, but there's certainly people who just don't, and we haven't quite identified what it is about one particular person versus another. But the most common side effects are fatigue, edema, or swelling, particularly around the eyes or the lower extremities. We have to monitor the liver enzymes, and it can cause some generally mild nausea. There's other side effects that are reported. We monitor blood counts. Muscle cramps can be a difficult one to manage, and occasionally some rashes and mouth soreness. So going back to that population of patients in that first study that had no response or benefit to the imatinib. So, again, this was a really exciting time for oncology research. This is right when we were starting to learn how to look for mutations and what mutations meant within tumors. And when they looked at the patients in that study, so these are the data from that actual first study, it showed that if the KIT gene had mutations in exon 11 or exon 9, the majority of patients had good responses. But if there was no mutation identified in KIT, then a majority of patients had progression of their cancer. And to look in this a little bit further, we also saw that exon 11 mutations responded just as well regardless of the dose of imatinib. But if the GIST had an exon 9 mutation, there was actually a slightly higher response to higher doses of imatinib, just suggesting that it wasn't quite as sensitive to imatinib. So what about those other populations? What about the 15 to 20% of patients where we didn't identify a KIT or a PDGFR mutation? And the signaling pathways that tell a cancer cell to grow are incredibly complex, and they don't work in isolation. There's a lot of crosstalk between these different types of signaling pathways, and so we have identified mutations most commonly within the RAF gene, the neurofibromin or NF. Also a molecule called succinyl dehydrogenase, amongst some others. And then we also identify that there are family syndromes. So families or kindreds that have mutations in their genes at birth that can lead to various GIST and other type of GI syndromes. So anytime we discover that a drug works in the metastatic setting, we then say, well, can we increase the chance of cure? And so that leads us to doing trials after surgery. And so the first study was done and reported in 2009 with 1 year of imatinib. And it showed that imatinib after surgery does delay the time to GIST recurrence compared to not having any imatinib. But then we recognized that after stopping imatinib, there are certain patients that started to have their GIST recur. So we did a clinical trial that looked at 3 years versus 1 year. So patients were randomized to either 3 years of imatinib after surgery or 1 year. And this was limited to GIST that were considered high risk based on that risk categorization that Dr. Prieta-Granata put up. So large GIST, high mitotic count, or GIST that happened to break open or rupture. And what this study showed is not only did it delay longer, imatinib delayed the time to GIST recurrence or coming back, but also patients lived longer. So this changed our standard of care for patients who have high risk GIST. We now offer 3 years of imatinib. So talking about some of those other mutations. So what happens if your GIST has a mutation that's not in KIT or the sensitive PDGFRs? And unfortunately, we don't have data yet about therapies that help improve the chance of cure in that situation. So a frustrating one has been a mutation in PDGFR, which I know I said is sensitive to imatinib, but there's this very specific mutation that is not. And I believe Dr. Davis will talk about some drugs available for that. Right now, we don't have any data that giving the drug that works for this is actually beneficial in that perioperative setting. And then we have no known therapies for these other kind of less common mutations, at least in the surgical setting. To touch briefly on what we call neoadjuvant or prior to surgery, imatinib, we have no randomized clinical trials that show what the degree of benefit is in this setting. However, we know just by monitoring and managing patients that there's definitely situations where doing imatinib before your surgery is helpful. So if the surgeon asks me to give imatinib before surgery, I essentially will give imatinib before surgery, because really the idea is to try to make the surgery easier. So can we downgrade the type of surgery that somebody requires? However, one, we want to know the mutation. We want to know that your GIST has, or the GIST has, a sensitive mutation. We also lose a little bit of information because imatinib works so well. We basically kill or turn off all of the cells, and so we don't get that mitotic count. We often don't see mitoses, or the pathologists don't when we go to surgery. So that can sometimes affect our ability to say, is this a high-risk GIST or not a high-risk GIST? And so that brings us to 2010, where we had the approval of the 3-year imatinib. And again, I just point out from discovery of, we didn't even know what this tumor was in the 90s. And it took about 10 years from identification of our mutation and drug to get a drug approved in the adjuvant setting. And that is it.
Thanks, Vicki. That was fantastic. I think in the interest of time, and because I don't see any burning questions in the chat, we're going to keep going. And then again, we'll regroup at the end for additional questions. I'm going to pick up the story where Vicki left off by talking about systemic therapy beyond imatinib. One second. Okay. These are my disclosures. So similar to Vicki, I like timelines and putting things in sort of context. So it was in 1974 that there was the first drug approved for soft tissue sarcoma as a whole, and this was doxorubicin. And then it was 27 years till the imatinib approval that you heard came about. So that was quite a dearth, where it was a sad time for people living with sarcoma, where really there wasn't much drug development going on. But thankfully, this century has been a different story. So just 5 years after the imatinib approval, imatinib got a second indication in sarcoma for DFSP. And then in 2006, we also had the approval of sunitinib for GIST. 3 years later, a drug called actinomycin was approved for rhabdomyosarcoma and Ewing sarcoma. And then 3 years later, we have a drug called pazopanib approved for non-adipocytic soft tissue sarcomas. Again, the following year, we have another approval for GIST in regorafenib, and 2 years later, trabectedin for the L-type sarcomas. Things kept going at a nice clip. In 2016, we had eribulin for liposarcoma, and then 2019, pexidartinib for another type called TGCT. 2020 was a big year for many reasons, but thankfully, including GIST development. We had tezemetostat approved for epithelioid sarcoma, but then actually 2 more drugs approved for GIST, ripretinib and avapritinib. 2021 saw the approval of nab-sirolimus for PEComa, and just last year we saw atezolizumab be approved for ASPS. So if we look, in the 20th century, we had 1 drug approved, but in the 21st century, we're doing a lot better with 14 approvals overall in sarcoma, and about 1/3 of those being in GIST. So I would say the future is bright, and there's a lot of interest in drug development in this space. So I think there's good reason to be optimistic. So if we look at this screen, this shows us on the left-hand side, this is the human kinome, which kind of shows the complete set of protein kinases that are encoded in the genome. So kinases are basically something that serve as key regulators of cell function and are a major target for anti-cancer drugs. So if we look at these small little circles that are fairly hard to see, but they're in blue and green, they're basically the targets of approved multi-targeted drugs and combination products. On the right side, we have the 5 drugs that are FDA approved for GIST. And you can see these are what we call their kinomes. So the yellow on these drugs denotes their KIT binding potential, and then the red acknowledges kind of their ability to bind to other kinases. And so this variety in target accounts for their efficacy, but as also their side effect profile. So you can see that imatinib kind of only has a few targets, but things like sunitinib, regorafenib, and ripretinib have many more binding sites, which is why they have many more side effects. So if we look at sunitinib, this was the second drug approved for GIST. It blocks KIT, PDGFR alpha, VEGF, FLT3, and RET. There are a few different dosing strategies that can be considered with this drug, either 4 weeks on, 2 weeks off, or a slightly lower dose used continuously. This was approved based on the study looking at time to progression, so how long it took the GIST to grow while on therapy. And they compared sunitinib to placebo and found that sunitinib on average, the median time to progression was about 27 weeks versus only 6 weeks with placebo. Main side effects that we see with this agent are fatigue, diarrhea, nausea, sometimes a rash on the hands and feet that we call hand-foot syndrome, with some redness or tenderness, sometimes calluses, and then mouth sensitivity. The next drug, regorafenib, so this blocks, again, multi-targets, including VEGF, KIT, RET, RAF, PDGFR, and FGFR. And it's approved in the 3rd line based on this study where, again, patients were enrolled and received either regorafenib or placebo. And in terms of the median progression-free survival, it was about 4 months longer in patients that received regorafenib versus those that received placebo. Unfortunately, there was no benefit in terms of overall survival. And again, side effects somewhat similar. We still see that hand-foot syndrome a fair amount with this drug, as well as high blood pressure, diarrhea, and fatigue, and the mouth sensitivity. They also noted some hair loss, hoarseness, and a loss of appetite. So this looks fairly similar to a graphic that Vicky showed earlier. So we know that imatinib, sunitinib, and regorafenib have markedly improved the treatment for people living with GIST, but we know that drug resistance remains very problematic. So this figure shows the KIT and PDGFR alpha receptor tyrosine kinases and demonstrates drug sensitivities for primary and secondary mutations. So the drugs that we've discussed so far, they are all type 2 multikinase inhibitors that bind to the ATP binding pocket, which is this right here. And only when it's in the inactive form. So there are secondary mutations that happen here in the activation loop, and those induce sort of a shift towards this active conformation, and they reduce the ability of the drugs to bind, which is sort of what Vicky was talking about before. So these next generation tyrosine kinase inhibitors that I'll talk about in a moment, ripretinib and avapritinib, were designed to try to overcome this resistance. So moving now to ripretinib. So this was a very novel drug because it's a type 2 switch control kinase inhibitor. And so it basically has a dual mechanism of action. And so it can regulate both the kinase switch pocket and the activation loop. So basically it kind of sits in here and it binds to the switch pocket and it prevents access by the activation loop, and it blocks it from kind of going into that active state. So it inhibits a broad spectrum of both primary and secondary resistance mutations, including the activation loop mutations, which had been previously very hard to target. And it's now approved for patients who have received 3 lines of TKIs, including imatinib. So the efficacy of this drug was evaluated in the Invictus study, which was a randomized, double-blind, placebo-controlled phase 3 trial. And this was for patients who had received 3 lines of therapy, including imatinib. And patients were randomized 2 to 1, which means twice as many people ended up in the ripretinib arm as did in the placebo arm. And patients did have the option, if they're just progressed, to then kind of do what's called crossover, go ahead and get the active drug instead of the placebo. The primary endpoint of this study was progression-free survival. And so this demonstrated that the median progression-free survival for ripretinib in that arm was 6.3 months, and in the placebo arm was only 1 month. The median overall survival was 15 months in the ripretinib arm and only 6.5 in the placebo arm, so suggesting strong efficacy. for this agent, particularly in that fourth line setting. Because it fared so well in the fourth line setting, it was decided to study it in the second line setting compared to sunitinib. So this is the INTRIGUE study, and patients were randomized 1-to-1 in this particular study. The outcomes from this study are shown here. So median progression-free survival was equivalent between the two arms, 8 months for ripretinib and 8.3 months in the sunitinib arm. On the right-hand side in the table, you can see the response rates. So on the far right over here, this is the entire population, also known as the intention to treat population. So everyone who was enrolled in the study and could be assessed. And you will see that the response rate between the ripretinib and sunitinib arms was not statistically significantly different. However, if we just look at patients who had tumors that had an exon 11 mutation, you do see that there was a greater response rate in the ripretinib arm than the sunitinib arm, so 39% versus 24%. They did some subgroup analyses, which means they looked at patients who had tumors with those different mutations that Dr. Keaty explained. So patients, they looked at exon 11, exon 9. They looked at the wild type tumors, which meaning they don't have a mutation in KIT or PDGFR alpha, and then other mutations. And the largest group in this study, understandably, was patients with KIT exon 11 mutations. Interestingly, when they looked over here on the far right, you can see this is basically a graph that's designed to show you that if your bar and your dot are fully on one side or the other, that means that that arm is favored. So you can see most of those, that is not the case. The only exception here is that the KIT exon 9, 11 patients seem to do better with sunitinib, but you couldn't really make heads or tails over the rest of it because they all crossed this magical line in the center. They did some additional correlative analyses in this study. So oftentimes when you're on a clinical trial, the study will require extra tubes of blood or sometimes extra tumor biopsies. And the purpose of that is to do these extra correlative analyses. And so in this particular study, they looked at patients whose tumors had that exon 11 mutation. And then they looked at people who then developed either an exon 13 or 14 resistance mutation in the tumor or an exon 17, 18 resistance mutation. And they found that patients who received sunitinib, who had the exon 13, 14, did better than patients that received ripretinib. And in patients with the exon 17, 18, they actually did better with ripretinib as opposed to sunitinib. So this kind of, we would call this kind of a small sample size. And so this has propelled a new trial that will be called the INSIGHT trial. And so this is going to be a phase 3 randomized multi-center open label study. And they're going to look at ripretinib versus sunitinib again. However, they're going to limit participation to patients whose tumors had a KIT exon 11 mutation and that have then developed secondary mutations in exon 17 or 18, because they think that their hypothesis or their guess is that this is the patient population that is most likely to benefit from the drug. So that study is not yet open, but they're currently identifying sites and probably will be open later this year. Within a clinical trial, we always learn something about the side effects as well. And so these plots here kind of show you the grade or the severity of the side effects that patients experienced. Grade 1 are the lowest or the least severe side effects, and grade 5 are certainly the most severe. So you can see that the most common side effects within this side is sunitinib and this side is ripretinib. The most common side effects within the sunitinib arm were fatigue, the hand-foot rash, and high blood pressure. And within the ripretinib arm, you can see that the most common was alopecia, which is also known as hair loss, fatigue, and I believe muscle aches. Patients, though, had significantly more high grade or more severe side effects in the sunitinib arm as compared to the ripretinib arm. So suggesting that ripretinib is slightly better tolerated, at least in this study. All right, so now we'll move on to avapritinib. So avapritinib is a type 1 kinase inhibitor. It is potent and selective for both KIT and PDGFR alpha in their activation loop mutations. And this is approved for a very small category of people living with GIST. So those tumors that have a PDGFR alpha exon mutation, including the D842V mutations. So those were the ones earlier that Dr. Keaty was mentioning are resistant to imatinib, and prior to this drug had been very challenging to treat. So we first saw a hint of efficacy for this drug in the Navigator study. So this was an open label 2-part dose escalation and dose expansion trial. So dose escalation, they were basically trying to increase the dose to find the right one, and then expanding it once they figured out what the best tolerated and most likely efficacious dose would be. And so overall within this, they had 56 participants who had the D842V mutant GIST. And this is a waterfall plot. So this basically describes tumor response. And so we have 4 lines here. This one is progressive disease, stable disease, partial response, or complete response. So basically anything below this dashed line means we usually infer that we're controlling the tumor because it's not growing. So it's stable or it's responding. And so for this, though, we can see that the combination of this partial response and complete response was 91%. So this is kind of unheard of in oncology. So not just in GIST or in sarcoma, but a 91% response rate to any medication is a really unheard of victory. So this was very revolutionary and exciting to everyone that tries to take care of these patients. So this is the 1-year duration of response, and that was 73%. The 1 year, the overall survival was 91%, and progression-free survival was 83%. So all very, very positive data. So this led to the Voyager study. So this was an open label randomized phase 3 trial, and it was looking at avapritinib versus regorafenib in patients with metastatic GIST. And again, if the GIST progressed, then patients who were receiving regorafenib could cross over and get the study drug, which was the avapritinib. And the primary endpoint, similar to our other study, was also progression-free survival. So these are what are called Kaplan-Meier curves. So they're trying to show you whether or not there's a difference over time between the 2 arms. And so in these graphics, there are 4 of these. So this is everybody that enrolled in the study or the intention to treat. This is patients who were receiving treatment in the 3rd line, meaning they'd had 2 other treatments for their GIST before this. And this was patients receiving treatment in the 4th line, meaning they'd had 3 treatments prior for their GIST. And then these were the patients with the D842V mutation within their GIST. And so the results of this study, what you want to see if a drug is efficacious or if it works really well, is that there's a big gap, which is basically what you see here. And so basically what this study showed was there was no difference between avapritinib and regorafenib in any of these other scenarios, only in this one. And so this confirmed that really D842V mutant GIST was the only space for this drug. So in summary, our general practice for first line treatment in metastatic GIST, if it's a non-D842V PDGFR mutant GIST, is imatinib. If they do have that PDGFR alpha D842V mutation, then avapritinib is reasonable. At every juncture, a clinical trial, if one is available, is always very reasonable to consider. And thankfully, there are many clinical trials available both at Vanderbilt as well as elsewhere. And I've just listed a few here that are currently open. The first 2, we actually have the second one open, the regorafenib trial, but those are specifically for those very rare subtypes of GIST, trying to develop novel treatment options, just given that historically the TKIs that are approved have not worked very well. The bezuclastinib plus sunitinib trial is also open at Vanderbilt. And has been for, I guess, about a year now or 8 months. And then many of these others, some of them are only open in Europe or other countries, but a few of these are open also within the US. But clinicaltrials.gov usually is a good starting place in terms of looking for clinical trial options. So that's all I have for right now. And I think we're going to keep going just in the interest of time. I think Dr. McGee is with us, so I will stop sharing so that she can share. Dr. McGee is one of our surgical oncologists, and she's going to talk to us a little bit about the surgical management of GIST.
Perfect. Thank you so much, Libby, for inviting me to talk today. I'm happy to kind of share my thoughts on the surgical management of GIST. And I'll share my screen. Hopefully can you see that?
Yes.
Okay,
Yeah, we
perfect.
can see it.
Perfect. As Dr. Davis mentioned, my name is Dr. McGee. I'm one of the GI surgical oncologists here at Vanderbilt, and I do a lot of complex GI surgery. And one of the pathologies I do help in managing, in addition to some of my wonderful partners, is gastrointestinal stromal tumor. So I'm going to talk a little bit about how we manage GIST from a surgical standpoint. So I have nothing to disclose. The outline of my talk is really to talk a little bit about the background. I know that's been covered in the previous lecture, so I won't go into too much detail in regards to the etiology, et cetera, but I'll briefly touch on that. I'll talk about the surgical management of GIST, kind of what to expect postoperatively following a surgical resection, be it in an open operation versus a minimally invasive operation. I'll discuss briefly 2 case presentations and the common cases that we see and how we approach these 2 cases. I'll talk a bit about surveillance, and I'll leave a little bit of time for question and answer, but if there's no time, we can go to the next lecture. So as you probably all know by now, and I'm sure you're all experts, GISTs are the most common soft tissue tumors of the GI tract. They result most commonly from KIT or PDGFR activating mutations. The annual incidences in the US is 0.78 per 100,000. So it's relatively rare, but we do see a fair amount. And Dr. Keaty and Dr. Davis are our 2 major medical oncologists who see the majority of these tumors here at Vanderbilt. GIST can really arise anywhere from along the GI tract, ranging from the stomach, which is the most common site of these tumors, all the way down to the rectum. The least common site really is the colon and the appendix, but we most commonly see these tumors in the stomach. They typically arise from the muscle layer of the wall of the organ of origin. So if it's from the stomach, it's extending from the wall of the stomach. So for GIST, unlike other adenocarcinomas or invasive malignancies, these tumors extend from the stromal layer and extend typically extrinsically or outwards rather than into the lumen or into the organ of origin. And so a lot of the morbidity or complications from these types of tumors arise from involvement of adjacent structures. These tumors do not typically involve the lymph node basin. Certain mutations can result in higher lymph node involvement, but in general, these tumors do not involve the lymph node basin. So the major role of surgery really is to resect the area of the tumor with negative margins, and not to perform a lymphadenectomy as we do in other malignancies of the GI tract. So these tumors tend to be very fragile in general, and they can rupture very easily and can actually bleed readily easily. So we are very careful when handling these tumors. Even a simple abdominal exam can cause rupture of these tumors. So I always talk to my residents when we're doing these operations that we have to be extraordinarily gentle when handling these tumors so we don't cause intraoperative rupture. The goal of surgical intervention really is to achieve a gross resection, a complete gross resection of the tumor and the wall that it's involving with a negative margin when we send it to our pathologist. So the majority of us will send our specimen intraoperatively to our pathologist to look at it under the microscope to ensure that we got a negative margin and make sure we don't have to take any additional tissue. So a lot of times, especially for gastric lesions, we are able to do segmental or wedge resections rather than anatomic resections as we do in traditional gastric cancer. Because these tumors typically extend from the wall and are extrinsic, And so we're able to do wedge resections of these lesions rather than having to do a formal partial gastrectomy and lymphadenectomy as we do with traditional gastric cancer. For GIST that require multivisceral resection, meaning if they are involving structures that are adjacent to the organ of origin. So in stomach GIST, the typical organ that it can involve is the spleen and the transverse colon, because these structures sit in very close proximity to the stomach. In those cases where we are going to have to do a multivisceral resection and remove multiple organs, we do often employ preoperative therapy with imatinib or another therapy that Dr. Keedy or Dr. Davis recommends based on the exon mutational analysis. So in terms of NCCN guidelines, it's relatively straightforward in terms of how we manage gastric GIST. And I'm talking about gastric GIST for the most part, because these are the most common tumors that we see. So what the NCCN guidelines shows us, which is the really foundation in terms of pathways for management of different types of tumors. The tumors that are extremely small, so less than 2 centimeters, can be watched if they have very low risk tumor profiles. However, that it is really rare that we see low risk small GISTs in general. Those with higher risk features do require surgical resection up front. For those that are a little bit larger, so greater than 2 centimeters, we typically recommend, obviously, endoscopic evaluation, biopsy via EUS, which is an endoscopic ultrasound. And then we always want to rule out metastatic disease. So we obtain imaging of the chest. And if the patient has non-metastatic disease and it's localized to an organ of origin without involvement of adjacent structures, then we typically recommend surgery up front. And then if we're considering preoperative therapy, we enlist Dr. Davis and Dr. Keedy to assist us in giving the appropriate preoperative therapy if we feel that the surgery is going to be significant or extensive or have high morbidity or complication risk. So typical gastric GIST locations, the most common site that we see are really along the greater curvature of the stomach, which is the long part of the stomach, as you can see here. So 75% of the tumors that we see involve this location. And I'll be honest with you, these are my favorite tumors because they're very easy to remove in general, because we're able to do these minimally invasively and essentially wedge out these tumors for the most part. When we start seeing tumors along the lesser curvature of the stomach and closer to the GE junction, these can be a little bit more challenging to manage, because the biggest issue is narrowing the inside of the stomach in these specific areas. So oftentimes we use robotic techniques or open techniques to ensure that we don't narrow the lumen of the structure that we're removing it from. Esophageal or GE junction GISTs are pretty challenging to manage because the diameter of the esophagus is relatively narrow. So in those tumors, we typically employ preoperative therapy to try to shrink the tumor as much as possible to decrease the morbidity of the operation and decrease the risk of having to do an esophagectomy, because it's very challenging to be able to remove the tumor and not worry about the lumen or narrowing the lumen of the esophagus, which can obviously make swallowing and eating very challenging. For resectable GISTs, this is also from NCCN guidelines. We do baseline imaging, mutational testing. We talk about primary therapy being either medical therapy with a targeting agent versus upfront resection. But in locally advanced tumors that are involving adjacent structures, again, I usually recommend preoperative therapy with Gleevec or another therapy just to try to decrease the morbidity of the overall operation. What I found over the years is that the typical tumor doesn't necessarily shrink away from the adjacent structures, but oftentimes you can find a plane that will make the ability to leave the adjacent structure behind possible. Whereas when the tumor is directly invading or pushing on the adjacent structure preoperatively without any therapy, it's very difficult to be able to remove the tumor without removing the adjacent structure. So that's where preoperative therapy really helps. So in terms of surgical approaches, I'm just going to touch briefly on the different approaches. The two most common ways we do things are minimally invasively or open. Minimally invasive techniques involve laparoscopic or robotic approaches. And this is just a picture of a robotic resection being done. So this is the tumor here coming off of the greater curvature of the stomach, and we're able to essentially wedge off the greater curvature of the stomach along with the tumor. And then we always send that staple line to our pathologist to ensure that it's a negative margin. So when we talk about small bowel GISTs, these are 30% of all GISTs. I see a fair number of these. And most commonly, I see these in the recurrent setting. A lot of times patients present to community hospitals or other facilities with a small bowel obstruction, and they have a primary resection of a mass. And then a couple years later, they end up having some sort of recurrence. And that's the most common time I see them and get involved. So typically for small bowel GISTs, they require a small bowel resection, and this comes down again due to the narrower caliber of the small intestine. Similar to the esophagus, you worry about wedging off the tumor because you can really narrow the lumen of the small intestine and make digestion very difficult, leading to a bowel obstruction. So what we typically do is resect the site of the tumor along with the small intestine segment that it's involving, and then do an anastomosis or a connection between the small bowel proximal and small bowel distal to where that tumor was. And many different types of approaches are used. We use a laparoscopic, robotic, and open options. I tend to do these laparoscopically if possible, and if not possible, I can do it robotically or open, but they're all, tried and trusted ways to resect the small intestine. So how do you know if you're a candidate for surgery? I think, if it's a unifocal lesion and you don't have multifocal disease, surgical therapy is typically the mainstay of therapy. We talk about curing disease. I use that term very heavily, I should say, not lightly, because it's really impossible to say cure in most malignancies. But I think with GIST, especially when it has low metastatic potential, and I'm sure Dr. Davis and Dr. Keaty have already gone into the factors that lead to metastasis from this. I think we can achieve a cure with surgical resection. So in unifocal disease, from especially from the stomach, if we achieve a negative margin, typically we can achieve at least long-term disease-free survival. If the GIST has spread already, typically surgery is not offered unless it's in a palliative type setting, or we are doing a debulking if the patient has been on some sort of therapy and is having a really good response and they have 1 or 2 sites of remnant disease, then we can recommend surgical intervention. But in general, in the setting of metastatic disease, we typically do not operate unless the patient has some sort of obstruction or bleeding complication and requires some sort of palliative operation. And obviously, performance status and patient's health is really important. So patients who are not in the best of health for other reasons, not necessarily due to their primary tumor, surgery, just like chemotherapy and immunotherapy, can really affect patients, and it can really cause decline in patients who have significant performance status issues to begin with. So we have to keep that in mind when we offer major surgical resections. And then what to expect post-surgically. The majority of patients bounce back relatively quickly. Most patients are in the hospital, especially for gastric cysts that are you can do laparoscopically or robotically, are in the hospital for two to 3 days. If it's a more extensive operation requiring a multivisceral resection, patients can be in the hospital anywhere from 5 to 10 days. So it really depends on the extent of the operation in terms of what to expect. In general, for laparoscopic and minimally invasive approaches, patients' pain management is a little bit easier. For open operations, pain can be a little bit higher in general, but we typically recommend a good pain regimen post-operatively so pain can be well controlled. So I'm just going to talk really briefly about a typical case presentation. I know I have limited time left, so I'm just going to briefly touch on 2 typical case presentations. So the first one is a patient that I've seen. It's a 54-year-old male who presented to me with mild epigastric abdominal pain, so that's upper abdominal pain. He had some early satiety, but there was no nausea or vomiting and no bleeding with his vomiting. He goes to his PCP initially, and they recommended a CAT scan. And the CAT scan shows this mass that's emanating from the greater curvature of the stomach. And there's an arrow that's pointing to the tumor. And you can see that it's extending from the wall of the stomach rather than going intraluminally or into the stomach. It's actually extending outwards. And you can see here it's adjacent to the liver, but it's not really involving the liver. So for this patient, what we typically do in terms of workup, we do an endoscopy as well as an EUS, and we obtain a biopsy of it. And the biopsy had shown a GIST c-KIT positive, which is the most common type. And in terms of this tumor, given its size and location and ease of operation, we offer an upfront surgical resection of the lesion because it also doesn't involve any adjacent structures. So we offered him a laparoscopic GIST resection. Now, this is just an example of a similar patient that had come to see me, but with a very different looking CAT scan. His CAT scan, unlike the first, did look like it was involving adjacent structures, including the spleen, the tail of the pancreas, as well as the wall of the stomach, as we know where it's emanating from. And given the involvement of the distal pancreas as well as the spleen, we opted to do preoperative therapy first. And with this patient, we gave him preoperative Gleevec, and we surveilled him every 3 months. And we were able to achieve some decrease in the size of the mass. Unfortunately, intraoperatively, it still did involve the pancreas, and I was unable to find a plane between it. So he did end up requiring a gastric resection along with a distal pancreatectomy and splenectomy. But the size of the mass was decreased by the addition of the preoperative Gleevec. So as I mentioned before, in general, when we do preoperative Gleevec, and I'm sure it's going to be discussed later, we surveil these patients every 3 months to ensure that we're achieving response. And if we're no longer achieving response, we have to discuss intervening at that point. But if you continue to get response, you can continue with the therapy as long as the patient's performance status is okay and they're tolerating the therapy well. So I'm not going to go into risk stratification too much because I think this has already been discussed earlier. But I think the most important thing to think about is the larger the tumor and the higher the mitotic rate, and location matters in terms of the risk of development of metastatic disease as well as progression of disease. So location matters, size matters, and the mitotic rate matters. And this just kind of reiterates that as well in terms of the metastatic potential. And I know this has already been covered as well, so I won't go into the expertise of Dr. Keaty and Dr. Davis, but in terms of surveillance, for completely resected primary disease, I tend to see these patients every 3 to 6 months for 3 to 5 years, and then annually I get scans after that. less frequent surveillance is required for really small tumors because they have low risk of development of metastatic disease or recurrent disease in the future. And then more frequent imaging surveillance is required for higher risk tumors and those who stop their adjuvant therapy. So with that, I'd like to say thank you, and thank you for having me today, and happy to take questions at the end.
Thanks, Dr. Migi. I appreciate it. I think there is a question maybe in the chat. You could just respond to
Yes.
who did have a question for you.
Yes,
Okay,
absolutely.
so in addition to offering surgery and medication here at Vanderbilt, we also feel like it's very important to take care of the other aspects of each individual. And so we have several experts who have joined us for the latter half of our program today that are going to focus on some of those things that I think really make us sort of a unique, not just GIST program, but sarcoma and cancer program overall. So I'm thrilled that our first guest that's here with us today is Dr. Klein Quiros from the Department of Physical Medicine and Rehabilitation. And so she's going to talk about the role of her specialty in kind of helping people with cancer and how it's used as part of the cancer treatment program. So thanks, Christina, for joining us today.
Thanks for inviting me. I'm thrilled to be here. Let me share my slides. All right. Can you see that okay?
Yes, it looks great.
Okay, great. So, like Dr. Davis already said, my name is Christina Klein-Quiros. I'm our cancer rehab physiatrist or physical medicine and rehab physician. We are somewhat a newer subspecialty, so a lot of folks don't know that we exist or what we do. So I'm thrilled to be here to hopefully increase some awareness about what we do, how we can help in cancer rehab in general. All right, so just to get us started, what is cancer rehab? And what I've highlighted here is a definition that's been published, written in part by lead author Dr. Silver, and it really highlights that cancer rehab is medical care, and it should be available and integrated throughout that oncology care continuum. So meaning when folks first receive their diagnosis, if needed, during their active treatment, well into their survivorship, or if needed into end of life. It's provided by trained rehab professionals, so me as the physiatrist, but also our, wide-ranging team members from physical therapists, occupational therapists, speech language pathologists. Our goal is, hey, how do we diagnose and treat what is contributing to a functional impairment or something that's impacting quality of life, with the big picture goals of how do we maintain or restore function, reduce symptom burden, maximize independence, and improve quality of life. And I have to thank our oncology colleagues because otherwise I would not have my job. But essentially, as treatments have progressed and they've provided such high quality care, folks are living longer and longer. And you can see this significant upward trend in terms of the numbers of cancer survivors compared to the 70s up until 2022. Okay. And in order to achieve those goals, folks are receiving a variety of treatments, sometimes multiple treatments, like you've already heard about different surgeries, chemotherapies. Some folks need radiation, hormonal therapies, or targeted therapies. However, these therapies can result in numerous potential side effects, which you see listed here. And so that's where we're hoping to come in. Our goal as a new subspecialty is really to fill those unmet needs. And this is one of the earlier studies by Dr. Andrea Chaville up at Mayo. And this was individuals going through their cancer treatment, identifying their own needs. And I just wanted to highlight a few pieces from this graph. And so you can see here, over 70% of folks receiving cancer treatment had some sort of symptom, with the most common one being fatigue, and also really high rates of over 65% having some sort of functional impairment, with the most common one being difficulty performing activities of daily living. So things like getting dressed, going to the bathroom, taking a shower. And so again, that's where we're hoping to step in and really grow our cancer rehab line. Because of this, there's a an emphasis on increasing awareness. And this is, I just wanted to highlight this really landmark article that was put out by the Institute of Medicine. And that highlighted the fact that folks get lost in that transition from cancer patient to cancer survivor. And it is really important and essential to make sure we're thinking about what makes them feel like a person and a human being, and how do we then intervene to enhance function and quality of life. So that's where your rehab team comes in. So me as the physiatrist, our occupational therapist, physical therapist, speech language pathologist. Sometimes when people are sicker and they need some additional care, they may be in inpatient rehab, at which point they're getting additional rehab team members. So specialized rehab nursing, social work, neuropsychology. Additionally, folks may need a prosthetist and orthotist helping out with those either bracing or other needs, similarly providing adaptive equipment, assistive devices. All right, and just I'm done speaking. I wanted to make sure I highlighted what my role was. So my role is really to provide that evaluation, diagnosis and treatment. So, hey, what is contributing to the pain, to the difficulty walking, to the weakness? Do we need to order things to dig further, like x-rays or MRIs? Do we need to get blood work, or do we need to get some electrodiagnostic testing, which is a special test to look at muscles and nerves in more detail? Prescribing medications as needed to help with pain or that muscle tightness, recommending bracing, assistive devices, adaptive equipment, so that way we're maximizing independence with different tools that people may need at home. Providing really targeted referrals to my fabulous rehab colleagues, our PTs, OTs, SLPs that I've already mentioned a couple times. I do perform procedures. And then one really important piece to me is providing education. So, hey, what's going on? What are the range of treatment options? And what is the best plan for that individual person at that point in time? And that's one of the really neat things about rehab is it's adaptable, it's individualized, and it can change with time. So, the right plan for that person at this point in time may be completely different 6 months later, and that's okay. Our role is just to adapt and grow. And then within that, making sure we're coordinating that care between the rehab team as well as the oncology team. This is the question I tend to get asked a lot about, is what procedures we do. So it can be trigger point injections, so little injections into muscles, some steroid injections into joints or the spaces around different joints or tendons, the injections around tendons, some Botox injections, as well as some nerve blocks. And I also wanted to highlight the important role of exercise and physical activity for overall health outcomes. And this is a fantastic infographic that was put out by the American College of Sports Medicine. And this highlights the current levels of evidence and recommendations for exercise recommendations specifically for cancer survivors. So their general recommendation is overall, we're trying to avoid inactivity, improve general health, and work towards building up physical activity through both aerobic exercise as well as resistance or strength training. They then broke it down more specifically based on kind of different outcome measures. So fatigue, how you're functioning, quality of life, anxiety, depression. These are the areas where we've got really strong evidence of benefit. And they broke it down by the aerobic activity, meaning walking, jogging, stationary bike, swimming, dancing, some intense gardening, any of those activities that get you up and moving. That's one of their breakdowns, as well as the resistance exercises, meaning either body weight, little resistance bands, little free weights, or, get creative at what you've got at home, a can of soup, a water bottle, to make sure we're working those major muscle groups, and then the combination. One of the key takeaways for me is gradually building up the aerobic activity and working towards those 150 minutes a week of moderately vigorous aerobic activity. What they mean by that intensity score, they've got it based on some fancy heart rate calculations, so we don't need to do those to get a general sense of where we are. For moderate intensity activity, you're pushing yourself to the point where you can still easily talk, but it would be hard to sing. And that counts as moderate intensity aerobic activity. If you're feeling good, you want to push further to get to vigorous activity. That's the point where it's hard to talk when you're doing that activity. And if you are doing vigorous activity and you're thinking about those 150 minutes, vigorous activity minutes count for double when we're working towards that total. For the resistance exercises, it varies a little bit in terms of the data, but anywhere from 8 to 15 reps, really trying to hit those major muscle groups and making sure we're balancing those out. So not just working, the front of the thigh quad muscles, but also making sure we're working the back of the thigh, the hamstring muscles, so we're balancing those muscles. Okay. All right, so just in conclusion, a few key takeaway points I wanted to highlight is that how you feel, how you move, and how you function is important. And it's really common to experience these symptoms or functional impairments related to cancer and its treatment. And our rehab team is here to help. So please feel free to reach out to us or your local cancer rehab team. All right, thank you. Any questions?
Thanks, Christina. That was fantastic. I think we're glad that you are a newer subspecialty and that you are here at the Cancer Center. We feel very, very lucky to have you right here with us. So we're going to keep going and actually to one of your colleagues over at the Diani Center, which is very close proximity to the Cancer Center. And Julia Russell, one of our physical therapists, is here today to provide some insight about what Diani can offer to our patients.
Hi, my name is Julia. Can everybody hear me? Okay.
Yeah, we can hear you.
I don't have any slides, so we just get to look at my pretty face. But so I just wanted to share with you guys a little bit about PT in general at Diani, and then also just sort of piggybacking a little bit from Dr. Klankiros about the importance of exercise, both cardiovascular and resistance training. So really, again, to reiterate, the goal is to move, and the goal is to move as much as you can tolerate and really try to work your way up. Again, trying to get to that 150 minutes. If you can only do 10, if you can only do 5, start with that and then build your way up. It's not like you have to start at the 150. While you're doing that, make sure that you're drinking plenty of water and you choose something that you like. Movement should be fun. If you hate hiking, don't hike. Find something that you enjoy that gets your heart rate up and gets you feeling good about yourself. Another thing that to really sort of focus on is the resistance training, again, either with free weights, resistance bands, machines, and then being sure that if you are going to incorporate resistance work, that you need to be staying inside of your lifting restrictions if you have any post-operatively or any surgical restrictions, and not pushing yourself past what your body can do at that time based on your surgery and your procedure. So always be sure to default to any questions to your provider, to your surgeon, if you have those about getting into resistance work. So with resistance kind of therapy or resistance work, the goal is really to increase your muscle strength and to improve your muscle endurance so that you can do those daily tasks that a lot of people have trouble with functionally, whether that's getting out of the bed, getting off of the commode, doing stairs, whatever it is that's tough for you, the resistance training is going to help. So trying, if you are on your own for it, trying to do somewhere between 8 and 10 different types of multi-joint exercises, again, inside of your restrictions, whether they're squats, lunges, push-ups, or rows in a squat, something that you enjoy that can incorporate a lot of different body parts all together. If those are not accessible to you, or you don't have the tolerance or the knees or whatever to be able to handle it, then either doing laying down exercises or seated exercises, again, kind of reiterating what Dr. Klankiros said about making sure you're managing both areas, not just working the biceps, but focus on the triceps too, so that you can stay even. If you're having any of those issues, though, that we talked about with function, like you are having trouble in some of these exercises, or you don't know where to start, just talk to your providers and see if you can get a prescription to the Diani Center. They can refer you here if they feel like that is something that would be beneficial for you. And then we can really hone in and make the treatment specific to what kinds of functional tasks are difficult, so that you can really get and enjoy the life to the fullest degree. So again, if you're having problems, that's where we come in and we can help you get stronger, whether it's with the core or the legs or the arms, so that you can lift your grandbaby or do whatever it is that you want to be able to do. So again, just to hone in, because we love it, the 150 minutes of moderate activity a week, aiming for, if you can, 30 minutes a day, 5 days a week, and then trying to do that resistance work in those 8 to 10 different types of exercises twice a week. We know that can help with fatigue, quality of life, general function, anxiety, depression, and sleep, especially while you're going through all of your cancer treatments. So just again, if you have problems, give us a call. I know I went a little bit shorter, but hopefully that'll kind of keep us on track too.
Yeah, we don't mind at all. And we appreciate actually your insight. And I think you and Dr. Flankiros brought up such good points, and sometimes things that we forget to talk about or we don't talk about enough in the midst of our very long treatment discussions about medications and surgical options and going over scans. And this is such an essential component of care, and it's really what allows us to do the other parts of care. So we're very thankful for both of you and your teams. We also have Victoria Gunsel with us. She's one of our dietitians in the Cancer Center. And so she's going to talk to us a little bit today about nutrition in cancer, because it's such a vital topic. And I know it's something that patients really often have a lot of questions about. And so Victoria, thanks for joining us.
Awesome. Thanks for having me. Can you hear me okay?
We can hear you perfectly.
Perfect. All right, let me get my screen shared. Alrighty. All right. Is that in presenter mode to you guys?
It's not in presenter mode.
Okay.
It's like they can see the slides in this one.
Gotcha. Let me. Is that better?
I think you want to hit like slideshow, because right now we can see like your next. Sorry, it is in presenter mode now.
It is.
Yes, because I can see your next slide.
Okay. Are y'all good now?
No.
Nope. Okay. Oh my goodness. Ah.
There, I would just hit the one like down the bottom underneath your main slide that just says slideshow. I would just hit 2, 3 to the right. Just keep going. The next, yeah, that one.
Is that not the same screen?
Oh
well, we'll just run with this.
I think
if
it's
that's
fine.
okay.
Yes.
Okay, perfect. Well, like she said, I'm Victoria Gensel. I'm the dietitian in the VICC. So I see all the cancer patients that come through the clinic. So a lot of gastric cancer as well, and just patients. So the main things that I look for when I'm seeing all the patients, I really want to, 1, prevent malnutrition, and then 2, make sure that we're really maintaining a healthy weight and muscle mass throughout the duration of treatment. And I also like to help manage some of those side effects and symptoms that come up as a result of a lot of the treatments, the chemotherapies, radiation, any of those that come up. So just to help you live your best life. So the main thing that I look at too and want to help prevent is malnutrition, and then this fancy word called cancer cachexia, which is basically just malnutrition caused by a chronic illness like cancer. So basically what that means, it can be characterized by weight loss, loss of skeletal muscle and fat loss, just dysregulation of metabolic functions, and then a reduction in food intake. So just really not eating really well. It's very prevalent, as high as 87% in patients with pancreatic and gastric cancers. So it can be pretty common, and we definitely want to help prevent that because it can also negatively affect quality of life for patients. So it can also reduce the effectiveness of some of those anti-cancer chemotherapies and increase the toxicity of some of those treatments. And it can also lead to increased mortality rates. So nutrition is very important just to maintain, make sure your body's staying nourished to let the cancer treatments do their thing. So general guidelines in a perfect world, this is basically how we would, I would love for you to eat your meals. So of course, this is the My Plate that the government recommends now. It kind of replaced the food pyramid a few years ago. So it basically breaks it down to half of your plate being those fruits and vegetables that we want, about a quarter of your plate being really good whole grains or any type of grains really, and then that remaining quarter of your plate being protein. So all of these food groups are definitely important as far as a balanced diet, just to get you different vitamins, minerals, and nutrients to nourish your body throughout these treatments. Some of the drugs and treatments can deplenish a lot of these nutrients and minerals in the body. So it's really important to kind of get a good variety of foods in. So as far as the protein goes, definitely getting plenty of protein into your diet, and one sort of protein at every meal and snack is great. So proteins can include, of course, like meats, eggs, beans, lentils, legumes, dairy products, things along those nature. So all of those are good to have in your snacks. Grains are very important as well. So those can include rice, pastas, cereals, all of those types of foods as well. So it's definitely more important if we can focus more on the whole grains for some added fiber as well. So, you know, try to make half of those grains whole grains. Fruits and vegetables, I have written there, eat the rainbow. So it's just definitely important. And it doesn't mean eat the rainbow like the Skittles. So it just means eat the rainbow, like getting a variety of different colors of fruits and vegetables, you know, a red apple, orange summer squash, or oranges, green broccoli, you know, all those different colors provide different phytonutrients, and they help benefit our body in different ways. So it's really important that we get a variety of those. Dairy, as long as we don't have any weight loss, dairy can be a good part of the diet, and it's helpful to do the low fat dairy if possible. So that can include yogurt, milk, cottage cheese. All of those have some good protein in them, as well as important vitamins and minerals that our body needs. So those are always a good option to have. Beverages. Ideally, hydration is definitely very important throughout chemotherapy and different treatments as well. So focusing on water, caffeine, free teas and coffees ideally would be best. However, any hydration, any fluids that we can get in will contribute to hydration. So some of the main difficulties I see with patients, of course, this is how we want to ideally eat, but sometimes that's not always going to happen. So we definitely like to help treat any of these symptoms as they come along. So weight loss being one of the more important ones that we want to prevent. So if you do experience weight loss, please let one of your providers know. We definitely want to focus on high calorie, high protein foods when possible. So that can be the difference of having steamed broccoli versus sauteed broccoli, or adding a little bit extra butter to your mashed potatoes, or if you want a banana, you know, smearing some peanut butter on that banana before you have it. So it can be a variety of different things to fit your lifestyle, but the more calories that you can pack into a small amount as possible, the more it'll help with preventing weight loss and maintaining your muscle mass as well during treatment. Another good thing to focus on is small, frequent meals. That way you're just introducing more opportunities throughout the day to consume extra calories in the diet. So, you know, it could be having anywhere from 6 to 8 small snacks instead of trying to cram in 3 big meals per day. So every couple hours, you're just setting up a goal for yourself to at least consume some sort of calories. Another good thing is to limit anything calorie-free or any diet products. So those don't really add a whole lot of nutrition and just kind of take up space in your stomach, honestly. So they're not going to provide you a whole lot of nutrition. If it comes down to weight loss and we just need calories in, I would much rather you do the regular full calorie version than stick to a diet option, because calories in and quantity of calories is more important at that time. If you notice that there's a particular time in the day too where your appetite might be the strongest, you can try to focus and make that your largest meal of the day. Typically, I've found that breakfast foods are better tolerated. So a lot of times people have a lot easier time eating a big breakfast and then maybe having those smaller meals throughout the end of the day. But you can kind of tailor it to your own needs as well. It can be a nighttime snack, you know, however fits in your schedule. And another tip that I like to help with weight loss is definitely smoothies or milkshakes. You can definitely blend a whole lot together and slurp it down with the straw a lot faster than you can eat a cup of yogurt, a whole banana, a cup of berries, and whatever else you put in your smoothies. It can be a lot easier to get in that way. Some other symptoms that are pretty common is poor appetite, or could be nausea, vomiting. So this is definitely where those small frequent meals will come in handy as well. That will definitely be recommended for most symptoms related to some of the treatments as well. So poor appetite, you know, sometimes I like to encourage people to schedule their meals. If they're not feeling hungry and you're waiting for you to be hungry to eat your next meal, you're probably going to be waiting all day. So try to stick to a schedule. Say you wake up at 8 a.m., try to eat within 30 minutes and then set a goal within 2 hours to try to eat something else. It can correlate with different medications. So if you know you take a certain medication at a certain time of the day, you can correlate a snack with that. Or if you know you're going to take a walk or take a drive, you know, have a snack while you're doing these tasks just to make it easier on yourself. Try not to skip meals if possible. And then again, choosing those milkshakes, smoothies, or even like a good old boost or ensure can also be a good way to get in some extra calories if needed. Those are convenient, so whatever works best for you. Nausea, vomiting is another big one. So a lot of times cold or room temperature foods are a little bit better tolerated when we're feeling nauseous. So avoiding hot and a lot of greasy foods might not sit too well on the stomach. So bland, starchy foods are usually best. So that can be mashed potatoes, rice, you know, oatmeal that's not too hot, a cup of yogurt, anything like that, that would just settle a little bit better on the stomach. A lot of times too, sitting in a room while food is being prepared, sometimes those smells can also make you a little bit nauseous while those foods are being prepared. So you're already building it up in your head that you don't want to eat it. Instead, you know, just step out of the room and then come back in when all the food's ready. You might be more inclined to eat it before you've had time to convince yourself that you don't want it because you're nauseous from the smells. So eating and feeling full too quickly with meals, it can be pretty common as well. So that's where those small frequent meals will come in handy again. You're going to hear me say that a lot with a lot of these symptoms. So just trying to put a small amount in your stomach as often as possible just to prevent any discomfort in that full feeling can help. Try to avoid drinking a whole lot with your meals if this symptom is occurring. You don't want to fill up on just drinking water while you can't focus on getting your food in. And so that last bullet point, make every bite count. I call it power packing. So power pack as many calories as possible into a small amount. That way, if you get too full after just a few bites, you're going to get the most bang for your buck from those few bites. Another big one that I want to harp on real quick is hydration. So definitely want to make sure we're getting plenty of fluids throughout the day. That can vary from patient to patient as well, but we definitely want to set goals for yourself. Always keep water on nearby. Keep a water bottle. If you struggle to get water in, you know, it could be flavored waters. It could be adding different fruits to your waters. Just something to help get in some of those fluids that you need per day. And anything that does melt to a room temperature will technically count as a fluid. So whether it's like broths or soups or popsicles, it can even be a boost or ensure protein shake. All of those will count somewhat towards your fluid goals. Okay. All right. We talked about some of the surgeries already. So there's a few different surgeries that that can affect your nutrition a little bit differently. So I definitely recommend meeting with a dietitian if they have to remove any significant portion of your stomach or anything that might affect your nutrition for a long period of time. The main 3 foods that I wanted to focus on were high fat, high sugar, and lactose containing foods. Sometimes those are a little bit more difficult to process, especially if they have to take a big chunk of your stomach out, or if they affect any part of the stomach to small intestine valve, anything like that. So you might be able to introduce these slowly back into your diet after a while. Just double check with your doctor or dietitian after a few months. So dumping syndrome is something I see commonly if the tumor is anywhere around that valve between your stomach and intestines. So dumping syndrome can occur, and that can be diarrhea, bloating, nausea, any sort of negative symptom that could be occurring. Basically just means that your body's trying to process your food too much. So we want to slow it down because it's introducing the food from your stomach to your intestine too quickly. So a good way to kind of help with dumping syndrome is introducing more of those whole grain foods that we were talking about earlier. So high fiber foods, and then we want to limit the high sugar foods. That sugar kind of will speed some of the food through our GI system as well. So candies, desserts, fruit juices, anything that's going to be too high in sugar, we just want to try to avoid to help with minimize some of those symptoms. Fatty foods and then spicy foods as well may cause some discomfort. So those are also things to kind of limit and look out for. So any fried foods, if you're doing any dairy products, avoid the whole milk. Go for the low fat options, avoid cooking with butters and oils, those type of things, and just avoid any spices or spicy additives to the foods as well until you're able to tolerate those. One more thing that I wanted to talk about real quick was probiotics. Probiotics are really important for gut health too after a lot of these treatments. Probiotics can be naturally found in a lot of our foods. So specifically yogurt, kefir, miso, sauerkraut, cottage cheese. Those are some good examples of foods with natural probiotics, that good bacteria to help our gut microbiome flourish. So with these, you want to have plenty of fruits and vegetables as prebiotics to kind of help feed those probiotics, but just to kind of get your gut microbiome a little bit back to normal. Those will help as well. But any other questions, or if you have specific surgeries, definitely want to recommend getting a referral from your physician to a registered dietitian for more help. All right, thank you for having me.
Thank you.
If there's any questions, put those in the chat and I'll be happy to answer.
Okay, that's amazing. Perfect. I really appreciate it. Okay, so yes, questions for Victoria, please enter them into the chat and she will work on responding to you. Next up, we have Lindsay Grisanti. She is the Cancer Center social worker, and she is absolutely amazing. And she's going to talk to us a little bit about her role and how she helps in the care of our patients. Thanks, Lindsay. We can't quite hear you yet. I'm wondering if your volume might be down.
What about now?
Yes, now I can hear you perfectly.
Perfect.
Great.
Thank you. I'm sorry.
Thank you. No worries at all.
Hi, everyone. I'm Lindsay Grisanti. I am the social worker that works with Dr. Davis and her wonderful team. Just wanted to go over, understanding the oncology social work role and helping address, the psychosocial dimensions that come with cancer care. As a social worker in this area, and any oncology social worker throughout the country, we help patients and families understand complex issues raised by cancer. will provide in-depth support, really assessing the psychosocial oncology needs. With a cancer diagnosis, we're at higher risk for distressors. And, you know, with a diagnosis, you're going to experience different mixed emotions. It be anxiety, anger, depression, fear, worry, and making sure that we allow this safe space to feel our feelings and fully understand them and really dissect the different facets of an emotion. But then also learning to prioritize our behavioral health and our mental health and how that is a huge part of this journey. And how we do this and how a social worker can help you navigate through this process is identifying your village. That's what I like to call it. So identifying your people. This could be your spouse, your children, significant other, your physician, your lay navigators, your pharmacist, volunteer services, our cancer center social worker, you know, even a psycho-oncology team, and even just joining a mentor program or peer-to-peer program, or finding that local support group in your area, building that village to help you get there and to navigate through. And also, you know, asking those questions and obtaining information. A social worker can be there with you during your appointment times. They can be available for you to sit with you during those appointments and encourage you to ask those questions and really understand the different parts and the different services that are offered to you in your cancer center. And don't hold back on your concerns. You know, we're going to advocate for you to advocate for yourself. You know yourself best. Yes, we have experts in so many different fields that will work with you, but you know yourself. So being able to discuss that with your team, and then prioritizing the self-care. So a social worker will work with you to get you connected to the many stakeholders in this process. But our big thing is to advocate to make sure that you are prioritizing care for you. And that care could be, you know, just making sure you're getting enough sleep and enough rest. I always tell my patients rest can be productive. Rest is so important for our bodies and for our time receiving treatment and receiving care. And then also, you know, like our dietitian, nutritional choices, you know, making sure we monitor those nutritional choices. And then also that comfortable movement, making sure that we're moving our bodies and not restricting ourselves in that way. And then finding those enjoyable activities. So a social worker can help you navigate finding different hobbies, different interests that you want to try, joining different groups, socialization things like a journaling club or a volunteer program, making sure that you're getting connected to your community and you're doing that social participation and doing those activities that you love and enjoy. And just remembering to breathe. That's important. A social worker can meet with you, offer that just safe haven to vent and to just breathe. Sometimes having just that moment of rest and that moment in that immediate experience, letting everything else around you in that doctor's appointment, in that infusion room, just come to a halt and allowing yourself to be just present in the emotions that you're feeling. It's really powerful. So a social worker can help you navigate through all these processes, as well as other areas of psychosocial need, if it be finances, getting you connected to our financial counseling teams, getting you connected to your psycho-oncology teams for a therapist or a med management provider, as well as just other community foundations to help with support or grant funding that you might need during that time. But just making sure that you get connected to your social worker in your clinical area and in your cancer center is so important and crucial, because we're here to be a support advocate for you. Thank you. That's all I have, Liv.
Thanks, Lindsay. That was great. I'm very appreciative
thank
of
you.
you, and we're glad you were here with us today.
Thank you.
All right, so we have one more person who's going to share her role within caring for our patients. So she's last but certainly not least, Miriam Green. She is one of our nurse navigators in the Cancer Center. So Miriam, do you want to share a little bit about your role in the care of our patients?
Yeah, absolutely. Hi, I'm Miriam. I am, like Dr. Davis said, one of the nurse navigators at Vanderbilt. So I'm a part of a navigation team consisting of both nurses, and then we have patient care navigators. For the nurses, the main part of our job is a lot of pre-appointment work. So we reach out to all of our patients when they're scheduled, kind of go over the appointment, go over their medical history of why they're coming. So that way we can just make sure that they're scheduled with the right provider, as well as sometimes patients need to see medical oncology and surgical oncology. And we try to coordinate so that those appointments can kind of be done close to the same time. So patients don't have to make multiple trips if possible, to avoid that. And then we work on getting all the records. So biopsies, scans, stuff like that, so that the doctors have everything that they need to, give their best recommendations for that first appointment and make it as fruitful as possible. And then after that first appointment, the patient care navigators will kind of take control of the navigation part, and they will check in with the patients periodically, and they're kind of there kind of as a bridge to Lindsay as well for some of the social needs. They can help with stuff like transportation, nutritional needs, financial stuff, and then they can also just help kind of direct patients in where they need to go for certain appointments and stuff like that. And are really just an ear to help kind of talk through stuff and just get patients whatever they need. And that's pretty much our navigation program. We also have some patient care specialists who help with the records as well. So patients might hear from them before the appointment. But we're really just there to try to do all the background stuff and make everything go as seamlessly as possible.
Perfect. Thanks, Miriam. Yes, and we appreciate you and the work that your whole team does to try to get us everything that we need so that we can offer the best opinion for everyone as they come to clinic. So the last person who's not going to speak today, but I would be remiss if I did not mention her, as she was instrumental in helping organize today. And she provides a key service to our patients, is Julie Bolger. So she's the manager of the patient and family. Oh, and she turned her camera on. And the Patient and Family Resource Center, which is an amazing space right off the waiting room in our clinic. And Julie is down there offering a wealth of information to our patients and their families and offering them support. And so we are incredibly appreciative of what she does. So if you're a Vanderbilt patient and you have not stopped in to meet Julie, please do. You will be very happy that you did. Dana, do you have any last thoughts you wanted to share?
Yes, thank you so much to all of you. And I just want to ask Sarah Rothschild, LRG's Executive Director, to unmute, and also Laura Kuzi, Deputy Executive Director of the LRG, herself as well. I'm sure they want to say a few words.
I'll go first. Just want to say thank you to everyone at Vanderbilt. This is the second virtual event we've had with them. They've been wonderful in the planning, and your expertise is just amazing, and your team is wonderful. And it just makes me feel good every time I'm in your presence, all of you. So thank you so much. Appreciate it. I'm going to turn it over to Sarah and she'll close it out. Have a good weekend, everyone.
I just want to echo Laura. You guys have a great comprehensive team. It's nice that you were able to feature everybody's area so that patients know that your center has a lot of different specialties that can service them. It's been wonderful to work with your team on putting this event together, and I just want to say thank you. And it's just been a pleasure to hear the presentations today, and I want to also thank everybody for participating. So I will close this out and say to everybody, have a wonderful weekend, and thank you so much for joining.